Relevant, I guess, because diabetes is such a big problem for us. So it's very common to have both patient who is diabetic, with or without diabetic retinopathy, and coexistent cataract. So we'll examine some issues related to how cataract impacts your management of diabetic retinopathy, and also how diabetes affects your cataract surgery. Right, I think we are really facing a worldwide epidemic on diabetes. Many parts of the world are seeing double-figure increases. In Southeast Asia, we have about an average rate of 10%. Doesn't sound high, but if you look at population itself, global burden of diabetes is going to be huge, and it already is more than many countries can handle. Yeah. If you look at overall, the rate of diabetic retinopathy is about 10%, right? Sight-threatening, 5 to 10%. But even then, just in terms of pure numbers, we are really behind the curve in trying to solve the problem of diabetic retinopathy. And you know the two sight-threatening complications are diabetic macular edema and proliferative diabetic retinopathy. Good screening techniques, early screening recognition, hopefully with artificial intelligence, that will help in earlier detection, but that still does not reduce the burden of treatment of diabetic retinopathy. Let's start first with what are the risk factors. Why is this important? Because even before you handle the patient with cataract and diabetes, we want to know who are the ones who are most at risk of diabetic retinopathy, right? Duration, by far the most important. Anyone who has had diabetes more than 10 years, higher risk. More than 20 years, even higher risk. 30 years, almost definitely they will have some form of diabetic retinopathy. Glycemic control, obviously, right? Poor control, very common again in our situation. Most of our average HbA1c is what, 8 to 10%. In the West, maybe 6 to 8%, but really glycemic control is a big challenge, not only for us, but our colleagues. Type 1 versus type 2 diabetes gives you different patterns of diabetic retinopathy. Type 1 tends to give you more proliferative disease. Type 2 tends to give you more diabetic macular edema. But these are not exclusive, you can have both. Concurrent disease is really important. And among those that you recognize are hypertension and so on. One which is often missed is sleep apnea syndrome. So these patients have obstructive airway disease, hypoxia, especially when they're asleep. And they greatly aggravate diabetic retinopathy. And then finally, surgery. So what we're talking about these past few days, any kind of intraocular surgery, in fact, even YAG capsulotomy has been shown to give you a slight increase in aggravation of diabetic retinopathy. But certainly intraocular cataract surgery is a major risk factor for progression of diabetic retinopathy. Now, is control important? I think the evidence is quite uncontroversial. It is clear that the better your control, the better you are at slowing progression, preventing complications from diabetes. This is just one big study called ACORD, and you see a statistically beneficial effect of intensive glycemic control. So if anyone tells you, well, who cares? We don't really need to control the sugar, think again. Because this is one case, 20/30 vision with center-involved macular edema, poor control, we send the patient away, come back with better control, and you see that it can be reversed. So early diabetic macular edema can be reversed with timely intervention and appropriate treatment of the diabetes. Similarly with hypertension, right? This is the effect of losartan, which is an angiotensin renin blocker. This is one such case when you have BP poorly controlled, fluctuating especially. And then when you control the BP, the hemorrhages disappear. Right? So fundamentally, diabetes is a systemic disorder. We have to treat the patient holistically. So what are the pre-op considerations? Let's say a patient comes, he's diabetic, he's had diabetes for 10 years, and you suspect that that might be a problem. First, you have to check the retinal catheter. Does he have existing sight-threatening diabetic retinopathy? Pre-op considerations would be good glycemic control, make sure there is no evidence of ocular surface disease or infection. I think in such cases, when you expect problems, you want a more experienced surgeon to do the case if possible. If there is already pre-existing DME, diabetic macular edema, you want to treat as far as possible to resolve it, or if not, at least to stabilize it. Otherwise, you know that after cataract surgery, you're going to run into a lot of problems with the retina. What's the point of getting a perfect cataract surgery done when you lose vision from diabetic macular edema? If you've got proliferative diabetic retinopathy, you want to treat that as much as possible. But sometimes you can't because the media does not allow adequate PRP. Fortunately, we have anti-VEGF agents. We can inject, calm the eye down, reduce hemorrhage, reduce neovascularization. But that's a temporary solution. It's not a permanent cure. You still have to treat the diabetic retinopathy after the cataract surgery is successfully performed. Now, there are many problems that are different in diabetic patients who go through cataract surgery. I'll list a few. In general, complication rates are higher in diabetic patients. The wound healing is delayed, possibly related to corneal hyperplasia. There's an increased risk of endophthalmitis, and you hear from Professor Baisan in a minute. Pupil rigidity, you just heard from Professor Panet. So it's not just trauma and surgical factors. Sometimes the pupil just does not dilate well. You know this very commonly in diabetics. Glaucoma is an issue. Many of them have primary or secondary glaucoma. And sometimes you miss iris neovascularization. Okay, so that worsens the issue, you get high fever and so on, intraocular. And photic retinopathy is more common because maybe surgical time is delayed. Intraocular lens, I think, is still a little bit of a concern. Sometimes we have patients who have intraocular lenses that are maybe not appropriate. You want a big diameter as much as possible, especially if you expect that you're going to do PRP. Fortunately, we don't have silicone lenses so much now. In the past, that will be an issue, especially if the patient undergoes vitrectomy and silicone oil. And I know that it's controversial, but I prefer not to have multifocal intraocular lenses. If I think I need to examine the retina and I may need to do further treatment. And certainly, if you have to do vitrectomy with IOL with multifocal, it's going to give you much more problems. Also anterior segment complications, I won't go through most of these. But posterior segment complications are really important. One of them is progression of diabetic retinopathy. Interestingly, with phaco that is uncomplicated, you don't really see a big increase or worsening of diabetic retinopathy. It is only when it is complicated, when you have problems with vitreous loss, PC rupture, long surgical time. So the key here is prevention. You anticipate that you might have progression of diabetic retinopathy. You want to get in and out as quickly and efficiently as possible. And then, of course, we have this confounding pseudophakic cystoid macular edema, otherwise known as Irvine gas. Irvine gas typically in a non-diabetic patient will occur 4 to 6 weeks after surgery. Higher if it is complicated, higher in BCCE and ICCE compared to phacoemulsification. How do you recognize it? Vision is good initially, and then maybe 3-4 weeks later, visual acuity drops. Right. Now with OCT, very easy, right? We don't even need to do fluorescein angiography. But the key here is usually there's a bit of inflammation, persistent flare, sometimes cells. And if you do a fluorescein angiogram, typically you'll see disc leakage. And this is what differentiates it from diabetic macular edema. So if it's just DME, you should not see disc hyperfluorescence or leakage. Right? This is purely inflammatory. We see this, of course, in the uveitic syndromes as well. Why is this important? Because if it is pseudophakic cystoid macular edema, you don't have to jab the eye immediately with anti-VEGF, which you would for DME. You can treat them quite conservatively, and most of the time they will resolve. So very often, it depends on how good your pre-op assessment was. Let's say you start off pristine eye, no diabetic retinopathy, no sign of pre-operative DME. Then I think chances are it's probably pseudophakic. But if you already had significant retinopathy, suspect Irvine gas. And the Irvine gas in a diabetic patient occurs earlier than in a non-diabetic patient. So even 1-2 weeks after surgery, you can have an Irvine gas kind of syndrome in a diabetic patient. First line, topical. Topical steroids and NSAIDs. Second line, I give an orbital floor, triamcinolone. And if that doesn't work, then an intravitreal steroid implant, unfortunately. But I want to spend the rest of the lecture reviewing what is our current treatment for diabetic macular edema in 2019. Right? As you know, diabetes DME treatment has undergone such a big change, right? We started out with ETDRS, focal and grid laser, and then with steroids, intravitreal steroids, and now, of course, our gold standard is anti-VEGF. So it has really changed the landscape and also the prognosis for managing patients with DME. In the past, we used to ask you to memorize the criteria for CSME, clinically significant macular edema. This is according to the ETDRS guidelines for treatment. Now we've got the OCT. It's changed. The paradigm shift now is to whether it involves the central subfield or not. If it does, it's called center-involved DME, and if it's outside, it's non-center involved. Also, the OCT allows us to examine the interface with the posterior hyaloid. Because if it's tractional, what's your treatment? It's surgical, right? No point giving injections. So let's say you've got center-involved, non-tractional DME, then the treatment in this day and age is anti-VEGF. And so we follow the guidelines. This is just one of the few guidelines, and many societies have come up with them. I find this the most practical. And if you have time, go to this reference. This was published in 2017, Ophthalmological. Let's go through this one by one. First, evaluate glucose control. So that's what we talked about. Optimize glycemic control. Next, determine whether it is significant or not. If the vision is down and it is non-center involved, you do not need to inject. All right? So we follow ETDRS guidelines for non-center involved DME. So this is the central subfield. Macular edema on the OCT map shows very clear it's outside. Give focal plus minus grid laser according to your usual practice. Okay? And most of these will settle. For those that are center involved, why do we stop using laser as first line? Because most patients do not have improvement in vision. That's what we want now. Right? So all these are center involved who underwent grid and focal laser. Most of the time they maintain their vision, but did not have improvement in vision. And that's why it's no longer satisfactory in this day and age. Because laser is inherently destructive. So what is the underlying pathophysiology of diabetes? There are actually three mechanisms. Right? So one is vascular or vasogenic, which is thought to be mediated by VEGF. Vascular endothelial growth factor causes vasopermeability, so leakage, and it causes angiogenesis, which is proliferation. So it's very neat, isn't it? Diabetic retinopathy is largely mediated by VEGF, vascular endothelial growth factor. But there are other mechanisms that you have to think about. Inflammation and neurodegeneration. There's clear evidence that VEGF is the main player, at least in the early stages of diabetic retinopathy. In DME, for example, you see that the levels of VEGF are higher than neovascular AMD. Interesting, isn't it? Why? Because it probably has come up, has accumulated over many years. And there is a correlation between the levels of VEGF and the thickness of the macula. So again, the biologic rationale for the role of VEGF is very, very strong. And that's why when we give anti-VEGF, it usually works. Now, what do we do in the first stages when vision is normal? 6/6, 2020, do we need to immediately treat all DME? This is an important question because patients are coming earlier and earlier. And the answer, which is recently from the results of Protocol V, is no. If the visual acuity is 20, 30 or better, you can afford not to treat immediately. What do you do in these cases? Tell the patients, get your sugars sorted out. Remember I showed you that first slide. Get your sugars sorted out and we will wait and see. If your vision starts to drop, 6/9, 6/12, then you can treat. And the result of the study proves it. In this study, 3 arms, aflibercept, laser versus observation. Right? Visual acuity is good. You see there was no difference between observation or laser or the anti-VEGF. Okay? Either in terms of visual loss or visual gain. So in summary, you can afford to wait in diabetic macular edema, but very, very different from neovascular AMD. In AMD, I would treat at 6/6. I would treat at 6/9. Okay? But DME, you can wait. Now, what happens, of course, with center involved? We talked about anti-VEGF. What is the evidence for this? RISE and RIDE, which is ranibizumab, VIVID and VISTA, which is the pivotal trials for aflibercept. I think by now you should know all this. This is ranibizumab. For the first time, we had an improvement in vision. All our previous trials with macular laser, maintenance, avoidance of moderate visual loss. Correct? Anti-VEGF changed our paradigm and prognosis for center-involved AMD compared to a sham. Even if you switch them later on to anti-VEGF, they don't catch up. So there is a limit, a time window of opportunity for you to treat and protect your macular photoreceptors. You wait too long, and that length of time, maybe 6 months, maybe 9 months, or 12 months, we don't know. You wait too long, you end up with irreversible damage to photoreceptors. DRCR-NET, this was from the US, also showed the same thing. With ranibizumab, better results than with triamcinolone and laser alone. And the question was, do we need to now give laser at all? With DRCR-NET, you can wait and defer laser. Can you see the blue line? Defer laser for at least 6 months. You only give it if you don't get the response that you want. So you can wait before you do laser. Give anti-VEGF first, at least for the first 3 to 6 months. Then add laser if you want to improve the response. Right? Look at steroids. Initial improvement, but after that the vision drops, mainly because of cataract. Right? You're giving intravitreal triamcinolone, you end up with cataract. We will deal with that issue later on. But the problem is, we are not giving enough injections. The RCR-NET and all the other trials shows, in the first year of any anti-VEGF agent you use, you need 7, 8, even 9 injections. This is something you cannot run away from. We cannot tell patients you only need 3 injections and then you are done. For the first year, intensive treatment is required if you want to achieve the same results as in these trials. 8 to 9 injections in the first year, 2 to 3 injections in the second. Some patients may balk at it, but this is the truth. And in the long run, it keeps them with that initial visual gain. They don't lose their vision because in the 3rd, 4th, and 5th year, they hardly need it. Key point, hit them hard, aggressively in the first year, and then you can take your foot off the pedal for the remaining years. Second year, 2 to 3 injections. After that, you may not need many more injections. Why is this so? Because anti-VEGF treatment is disease modifying. What do I mean by that? It causes regression of diabetic retinopathy. It improves retinal perfusion. We think that maybe the macular perfusion changes, and indeed, it improves perfusion. It reduces retinopathy. And therefore, you can see that there is a long-lasting memory effect of anti-VEGF. I mentioned triamcinolone. It works really well in the first few months. You dry the macula, vision looks good. But if the patient is faking,
The problem is pressure, IOP. In this case, 50% had either these, more than 10 or 30 millimeter increases, or needed medication, or more than 50% required surgery for cataract. And this is the thing that we are trying to avoid. We don't want to create a second problem just by giving intravitreal triamcinolone. So this is not the way that we manage diabetic macular edema now. We try not to give steroid if the patient is faking. This is for aflibercept, just to show you that their loading doses were different from ranibizumab. Ranibizumab is 3 loading doses, aflibercept we use 5 loading doses. So again, with that fixed dosing, even at Q8, that means 8 weekly dosing after the first loading doses, you need 9 injections in the first year. So you can't run away with doing less. And this are the results from Vivid and Vista. This is aflibercept showing very, very good results, similar to ranibizumab. Yeah. So if we have phakic eyes, but they have not been responding to anti-VEGF, so you've given already anti-VEGFs, not resolving, macular edema is still there, what do we do? Then we consider steroids. Right? We consider steroids. What is the definition of poor response? If you look at DRCR-NET, there were 4 patterns of response. The best one, more than 50%, early and consistent. So those are the ones who behave like the trials. You treat, 8, 9 injections in the first year, you get a good result. The problem is this group, the non-responders, which accounts for about a quarter. Okay. What do they look like? These are patients who have a drop in vision, DA consistently poor, so this is worse than 6/24. See the central subfield persistently more than 400 microns. That means you're not getting a good response with your anti-VEGF treatment. This is an example. This is the baseline. After 1 injection, no change, 2 injections, 4 injections, 6 injections, and then we added laser, again, no improvement. Right? Significant cystoid macular edema, subretinal fluid. In fact, if you look at the trials, up to 40% of patients actually never had their fluid disappear. Don't be too disappointed if macular edema persists, at least in the first year of treatment. Up to 40%. And 33% had fluid at every visit in protocol I. This is despite these patients getting 8 to 9 injections. So clearly, there is something else going on in these eyes. It's not purely VEGF driven. Why does this matter? Because if you have persistent edema, if you have fluid at every visit, despite getting the injections, you end up with poorer vision outcome. Makes sense, right? The more persistent your edema, the more likely you're going to get photoreceptor damage. So why are they not responders? Many reasons. Sometimes, in our context, probably not giving enough. That's probably the most problem, under treatment. But let's say you have been giving the correct number of treatments as prescribed. The most important is inflammation. That second major pillar of diabetic retinopathy. And there is good evidence for this. Inflammation, biomarkers for inflammation. Prof. Chi will probably be able to comment on this. Is clearly elevated in some of these patients, especially non-responders. These are slow-release devices that have been slowly coming into the market. The one that I use is the elegant one called Orgedex, dexamethasone implant, 700 micrograms. The pivotal study is called MEAD, M-E-E-D. And when it was first introduced, the company thought that these implants would last 6 months. But we know now that at most it lasts maybe 4 months. You have to retreat maybe about 3 times a year. You cannot give it at 6 months. Why? Because by the 4th month, vision starts to drop as macular edema recurs. Right? So the DEX implant works very well for first 2 to 3 months, and then after that, the effect starts to wane. So you have to retreat, at least for the first month. But you can find that with treatment, you get good resolution of diabetic macular edema. Now this is very useful when you have a patient who does not have a lens, pseudophakic. Why? Because when you take away the effect of cataract or cataract surgery, even triamcinolone does relatively well. Right? So these are patients who are pseudophakic. You see now that their results are almost as good as ranibizumab. Similarly, with the DEX implant, they don't lose their vision because of cataract. They maintain their vision. Right? So in pseudophakic patients, and those who are not steroid responders, steroid can be a first-line treatment for diabetic macular. So let's assume that we follow the current guidelines. The European, the Americans all use it. We start with anti-VEGF, right? When do we switch? When do we switch to steroids? Now, if you follow the DRCR net guidelines, you give at least 6 injections, then you add laser if it's not responding, and you wait 3 months for the laser to work. That means at 9 months you decide whether you want to switch to steroids, correct? So that's on average 6 to 9 months before you change. Why is that so? Because if you treat long enough, some of this edema will go away. This is from protocol I, that you have persistent edema at 6 months. At 1 year, 10% no longer have edema. At 2 years, 40% no longer have edema. And at 3 years, 60% will have resolved. So if you are persistent and you are patient, 60% after 3 years will go away. How many of us have patience for 3 years with repeated injections? That's a really difficult one, very difficult. And cost is also another issue. So can we predict, rather than wait 3 years, can we predict which are the ones who are unlikely to respond to anti-VEGF? And this was a nice study from Pravin Dugal's group. Based on the analysis of protocol I, it seems that there is already a clear separation into 3 groups after the first 3 loading doses in terms of visual acuity improvement, and they stay throughout the study in their swim lane. So it's like swimming in a lane, they don't cross, they seem to follow the same pattern. If they do well throughout. If they don't do well, they do poorly throughout. Similarly with the thickness, OCT thickness, at 12 weeks, if there is less than 20% reduction in macular thickness, it looks like throughout the study, they are going to do very poorly. Okay? So, can you then, at 3 months, make the decision? The answer is possible. So you can start to see the pattern within 3 to 6 months. So instead of waiting 9 months, or even 3 years, I'm switching, and most of us are switching earlier and earlier now. Why? Because early switching, between 3 to 6 months, gives you a slightly better outcome in terms of vision. Because you wait 3 years, and you are hoping for reduction in edema, and it doesn't come, by that time, if you were to switch them to a steroid, maybe too late. So when to switch? Now we switch between 3 to 6 months. Okay? This is also a practical issue. Many patients cannot come so frequently. The DEX implants last for 3 to 4 months, so it gives you a little bit more time in between, and you can reduce the number of injections. In this study, comparing bevacizumab and DEX implants. So that's one big advantage of steroid implants. Remember, you still have the problem of cataract if the patient is phakic, and you still have the problem of glaucoma, steroid-induced glaucoma. Next, what about patients who might have a contraindication to anti-VEGF? Now, you've heard a lot about the risk, systemic risk. We call that APTC events. APTC events are very well documented, life-threatening events such as stroke and MI, heart attack. Now, in the early days of anti-VEGF, we weren't sure. When we were giving it for neovascular AMD, we thought maybe we would cause more stroke, more heart attack, and deaths. But actually, if you look at overall, this is now hundreds and thousands of patients who were treated. That risk in a healthy individual is the same as the normal population. Anti-VEGF is safe if you do not have any pre-existing disease. But if you have prior stroke, congestive heart failure, pre-existing cardiac arrhythmia, the story is different. The story is different. That risk with an anti-VEGF goes up 5 to 10 times. Very few people tell you about this, right? And therefore, you can't use anti-VEGF in some situations. Let's say a patient just had a stroke. Within 3 months, I would try not to use an anti-VEGF agent. Okay? Similarly, this is from protocol T and protocol I, and you see that that risk is 36% in prior stroke, 20% with bevacizumab, 10% with aflibercept. Most times we accept risk of up to 5%. A normal individual, 3 to 5% acceptable risk. 10%, 15, 20% not acceptable risk. Bottom line is, if these patients are at risk, you should reconsider using anti-VEGF as a first line. And then the last bit I want to say is that diabetic patients are younger than AMD. And therefore, some of them may actually experience their problems in pregnancy. Right? You can have a pregnant woman with diabetic retinopathy, let's say she's type 1, and then you have to treat her. What do? Can you use anti-VEGF? The answer is no. We don't have enough evidence, and if there is a problem in pregnancy, she loses the baby, maybe not from the anti-VEGF, you will be sued, for sure. Right? And so, this is a real issue. Steroids then become our next option. Right? It's a viable alternative to anti-VEGF, especially in pregnancy. So the role of steroids is definitely no discounted. Patients who are non-responders, those who cannot come in frequently, by frequently we mean once every month or 2 months, because they will need 8 to 9 injections in the first year, pregnant patients, and patients who are at risk of an anti-VEGF agent. Okay? This is a 53-year-old man, 20/30 posterior subcapsular cataracts, increased cataract, so cataract surgery was done, uneventful surgery, but you can see already hemorrhages appearing, center-involved edema within 2 weeks. And in this case, it was deemed not to be related to erline gas. This was progression of diabetic retinopathy with DME. And the options, of course, were anti-VEGF or steroid. In this case, we opted for Orgedex, and 1 Orgedex was enough to settle it. So to summarize, diabetes and cataract are really common problems. They coexist. Complications following cataract surgery are more common. Anti-VEGF therapy is still the first-line treatment for center-involved diabetic retinopathy. But we consider steroids in several circumstances. Pseudophakic patients, patients who are not at risk of glaucomatous progression, patients who have risk, systemic risk, related to